we sure? Okay. So I'll do that again. So thank you everyone for coming. My name is Kevin Latraverse. Again, I work for ClearBridge Technology Group. We're a technology consulting and staffing partner to a lot of organizations throughout New England, throughout the country, from an enterprise IT, healthcare IT, and life sciences perspective. So like I said, booth 19, if you want to come by and say hello. Our next session today is titled Children and the Covid-19 Impact, presented by Dr. Oscar Bukstein, who's the Vice Chair of the Department of Psychiatry and Director of the Psychiatry Outpatient Services at Boston Children's Hospital. Dr. Bukstein attended medical school at the University of Texas Medical Branch in Galveston and has a master's degree in public health from UT Houston. At BCH, she's Vice Chair of the Department of Psychiatry and Director of Psychiatry Outpatient Services and a Professor of Psychiatry at Harvard Medical School, board certified in psychiatry and child and adolescent psychiatry, and has over 30 years of practice experience with particular clinical and research expertise in treating youth with substance use disorders and other disruptive behavior disorders. So please join me in welcoming Dr. Bukstein.
Thank you very much. Well, it's a pleasure to be here. We'll let the microphone make its exit. One of the things that happens when you're a child psychiatrist, or for that matter, any pediatric health professional, is you get asked about things related to children and bringing up children, even though it doesn't necessarily have to deal with mental health problems. In fact, just the other day, someone asked me, well, Dr. Bukstein, do you think women should have children after 40? And I said, well, I think it's obvious 40 is enough. In any case, hopefully we're going to talk. Now, I want to make a disclaimer. I'm not an IT person. In fact, I'm probably more toward the side of, well, if Dr. Bukstein can do it, anyone can do it. Anyone can do it. But I'm not afraid of technology, and we want things to get better and better. And sometimes they get better by planning and stepwise planning, and sometimes something happens that really pushes us into the future. And that's really what happened with COVID. Now, these are my potential conflicts. I have written a number of books and participate in something called Up to Date. I don't know how many people, we're actually going to mention Up to Date a little later today. But this really starts with COVID. 2 years ago, in fact, I think those of us in the medical center, in fact, I think all the hospitals date it back to March 13th, Friday the 13th, in which we were basically told to go home. No, it wasn't that simple because we're a hospital. Not everyone can go home, but deciding what are we going to do? How are we going to handle it? And even the next week, we realized we cannot leave our current patients by themselves. We just can't say, well, too bad, we can't see you. But also, we probably underestimated initially the effects of COVID, not only on the mental health of children, adolescents, and their families, but also the effects on really the health system, and particularly the mental health system. Now, I'm going to read some statistics to you about what COVID has done to the mental health of children. Those of you who read the New York Times saw on Sunday there was an article about how many kids are in the hospital or are going to the emergency department with suicidal thinking, suicidal behavior, severe mental health problems. In fact, on any particular day, a range anywhere from 30 to 60 or more children are housed either in the emergency department or up on one of the medical units in a bed meant for a medical patient at Boston Children's Hospital. Now, Boston Children's Hospital is about to open a new building. We're going to be a 450-bed hospital. 50 beds, that's 50 beds. That's that's more than 10% of the beds. And these, as you know, hospitals are used to being full. So why did they get there? Well, COVID-19, we know that increased social isolation, anxiety over health, stress of parents, just uncertainty about the school, having to have makeshift daycare arrangements, either with other family members or with friends or neighbors, the loss of pro-social activities outside the family, and of course, as related to technology, increased screen time. So really, the kind of experiments we don't necessarily want. Now, the last here is probably the most important, is decreased access to medical and mental health. Really, at least for a time, for about a week until we can get our act together, there was no outpatient mental health. You either went to the ED, where you would have to, well, we didn't know about the infectiousness of the agent, so you basically had to go in a hazmat suit to get in, but really access was really at a standstill. We have in the past 2 years, a number of different articles and papers that have been published that show that compared to before COVID to afterwards, the mental health deteriorated in a very significant way. Here's 14% of patients who reported who were worse in the eyes of their parents under the age of 18. So worse mental health status. Again, I don't want to spend too much time on this. Increase in suicidal thinking. We talked about the borders in the hospital, and it's very important. Well, we're going to talk about our response, obviously, and I'm just going to tell you a little bit about the Department of Psychiatry at Boston Children's Hospital. We have an inpatient services. Actually, we have 2 units, one that's in Longwood, where the big hospital is, and one out in the Waltham Hospital. And we also have another, what's called a CBAD. It's a community program, like an inpatient unit, less significantly staffed. There's not as many staff members because the kids aren't quite as acute. The number, of course, is the bed. So we control at any one time 40 inpatient beds. There's not a whole lot in the area. There's probably less than, probably less than 200, less than 250 beds in the greater Boston area. We have emergency services where we have 24/7 round-the-clock social workers in the ED who are supervised all the time by MDs, psychologists there to process all these kids. You're wondering where all these boarders came from. Well, they had to come through the emergency department. We have consultation services, and ours happens to be almost certainly the biggest consultation service in the world, medical psychiatric consultation services. We have outpatient services, and that's my job. I'm director of outpatient services. One is at Brookline Place near the main hospital, a brand new building, which we've been there for a year. And also a smaller one in Waltham. We have a partnership with a number of affiliated practices that have basically take care of about a quarter of the children in Massachusetts. Roughly a quarter of the practices, let's say, are affiliated with Children's Hospital, and they receive education training. They can receive consultation from psychiatrists, and we, of course, see them in our outpatient clinic if the children's severity of their psychiatric problems outstrips the primary care doctor's expertise or ability to take care of them. And I must say, we're very lucky in Massachusetts. The primary care docs have really stepped up to learn a lot of mental health, and learn a lot of mental health pretty fast over the last several years. So that's it. That's what the services that we have. But on March 13th, remember, that's when we feel like the pandemic really started for us. We have children and their families with limited access to the hospital. The only way they're going to get that week, that next Monday, the only way they're going to get care is if they come to the ED or they're in the hospital already and they receive a consult. No access to outpatient venues. We are closed. We hadn't, of course, had time to develop policies governing the safety. We really weren't sure how infectious and how lethal COVID was. So we had to develop that fast. Also, as I just said, there's an increase in demand. Not only is it bad in terms of access to existing problems, there's an increase and an increased need for services. So what are our solutions? Now, through the rest of the talk, I'm going to talk about what COVID forced us to do, but also I'm going to say that really we feel so successful and flushed with the success by these digital improvements that we are likely to adopt other digital aspects in the care of children and adolescents, and I'll talk to you about those. Okay, I talked to you about boarders. Those are patients needing a higher level of care, and they're housed in the emergency department on the medical floors. And what we needed right away in order to get these kids either home or to a CBAD or to an inpatient unit, wherever we did, we needed information. And right away, we created a database that allowed us to review, where the kid was from, what kind of problem they had, what their history was. So we could send this around to other inpatient units across the area, even ones in New Hampshire, Rhode Island, or what have you, to find beds. So we had a clinical database, and we still use it. I get a report that's sent to me, as well as other really clinical stakeholders, about 4 times a day. About 4 times a day to keep us up as to what is happening, really then and there. The link is always available if I want to, I don't have to wait till it arrives in my email. And these are the data points that we have for it. We have the clinician involved, the age, level of care, recommended disposition, and just some notes. So there we have something that we can really use to get these kids to where they need to go and get them there quickly. Okay, I talked about the increase in suicidal behavior. Now, this has been a problem. Now, people shouldn't say, before COVID, there was already an increase in suicidal behavior. In fact, pretty well noted during really since 2010, well, even before 2010. So we had, it became a little mini epidemic. So even before COVID, the Joint Commission decided to make suicidal behavior one of their primary goals, to reduce suicide attempts in the hospital. That's very important, but also a way to screen not just kids who come in for mental health problems, but kids who come in for medical issues. So we have a way where every kid, and this is being implemented at Children's Hospital, first in our department, you would think, yes, kids who have come in for psychiatric reasons should be screened for the most significant of psychiatric problems, absolutely. But we've been training nurses in the ED, nurses on the medical units, nurses in the clinics, to use a very well thought out screen. That's the ASK. It was developed by the National Institute of Mental Health. And so if that's positive, we have a whole protocol. Similarly, now the mental health folks don't have to do that because the ASK is essentially just one or two or three is a limited number of questions. We do the Columbia Suicide Severity Scale, which takes maybe 5 minutes if you have an extensive suicide history, maybe 10. It's easy for mental health professionals to learn because this is what we did on a non-structured basis for many years. We would get folks to, we would ask folks in a hierarchical manner. In other words, I would say, oh, do you feel hopeless? And they would say, yes. Do you wish you were dead? Oh, yes, that's death wish. Do you have thoughts of suicide? Yes. Do you think about ways in which you could do it? No, I don't think. I just think in general I'd be better off if I wasn't here. Maybe I should kill myself. Or they have intent. They said, yes, I've decided I'm going to use the knives in the kitchen, and I'm likely to do it in the next month or tomorrow or whatever. So we go up on that hierarchy. We have this on the EHR. We have this on the medical record now. So we can not only acutely look at people, that is flag people who go beyond a certain threshold of concern in order to safety plan, but we can also prompt physicians when this occurs. And we grade we take quarterly, we look at the number of people. Is everyone over the age of 10 has to have this? What percent actually did get it? What percent actually went through our policy, the different sets of our policy? And all of that is generated electronically from inputs in the medical record. Indeed, we even have prompts for completion. That is, if we haven't asked it, the computer will flash up and tell us to ask it. Outpatient services, as I mentioned, after the pandemic started, we didn't have it. But it just so happens that we had already started doing virtual visits. We had a pilot program with a number of the outlying pediatric practices and so-called mental health deserts. We had some of us, I had been in Texas, and we had been using limited, usually it was a clinic or a facility way out in West Texas. So if we were in Houston, we could sit there and interact and take care of these people. But the truth is, there's no limit. I don't mind if a person, our clinic is in Brookline. I don't mind if a person's on the other side of Brookline. I don't mind if they have to walk, if they could walk to the clinic. It's still nice to have a virtual alternative. So we had already started them for 2.5 years. And we had gotten to the point of just over 10% of our visits were virtual before the pandemic. The hospital understood this. In fact, we were one of the lead departments in developing our virtual capacity. And I think we understood. I told my boss, I said in 5 years, and this was probably a year before the pandemic, I said in 5 years, 50% of our visits will be virtual. Well, I didn't count on a pandemic because when we started up, it was 100%. And now I suggest that we will still be doing a majority into the future after COVID is reduced to just hopefully a modest concern. We will have a majority of virtual visits. It's here to stay. But we worked out the kinks because essentially everyone did. At some point, we allowed folks to come back for on-site visits. We, of course, are under the state mandates to, in medical facilities, to mask up and all. So we have folks who come in for evaluations. They usually come in on site. We've established a rule that we like to see people who are in ongoing care, and many of our kids have chronic care, that they would come in at least once a year for that. But the rest are virtual visits. One of the challenges on virtual visits, we realized it wasn't like, at least at the time, so much hybrid. Every patient was on a virtual visit. How do we get the information we used to get when they came in? You know, you're given a little sheet of paper, or now you might be given a tablet and you do all that. We had to do that. We had to figure out a way to do that. And it was first to email it out, email the forms out, and try to have them, or try to have them mail it back. So we tried several iterations of trying to get this done, and we're still not there yet. Ultimately, what we'd like to do is, either through the patient portal or through other means, to be able to send out an electric link that would allow them to complete this information, that would come directly, that could be subsumed into the medical record. So right now, our department is not there. And I should say that, you know, like every other hospital, we have an EHR, and you know, the EHRs sometimes, in some ways, are leaders, in other ways are not leaders. They basically respond to the needs of the hospital. And in this case, our needs are to be able to push out a number of different kinds of forms. I'll go through a few in a moment. This includes release of information forms, policies, attendance, clinical rating scales, and I'll mention that before, because that's important. We have really, the field has established something called measurement-based practice. That is, just as you would go to a pulmonologist or your allergist and you get lung testing, you know, they want a number. Everyone wants a number. Everyone wants to give you a test. Go to, if you're diabetic, go to a glucometer, or get other indices of a good blood sugar control. We want to do that. But our way is people fill out forms. People have to describe what they're like. We don't have any blood test for measuring disease in the same way other areas of medicine have. So we have to figure out, how do we get them the rating scales? And of course, staff. A lot of our staff, even though we have a front desk staff who was always there for a while, the staff wasn't on site either. So how were they going to communicate in home or the office? Now, I will say the future of virtual visits, why is it assured? Because it's too convenient. It's too nice. It may not be for everybody, but it's what people want. And it serves our purpose too, because if I have the sniffles, I don't want to show up at work. They won't let me come in. So what I do is I go home and I can have a virtual visit. No one is exposed to me. My patients aren't exposed to me when I'm at home and they're at home. Obviously, people had a number of different family responsibilities during COVID, such as childcare responsibilities. Well, this allows them to, it's juggling, but nevertheless allows them to do their job and still fulfill those sorts of duties. And of course, health equity, and I think this was something that we needed to address. This allowed at least our staff to do their jobs without worrying about going on the T and getting, or the bus and getting sick. And as you'll see, there are other reasons from the patient's perspective that to promote health equity as well. Now, I'm not going to go through this, and I don't want to spend too much time on this, but this describes our process in virtual visits. You see here in the upper left corner, the scheduler or intake person will schedule this in using the computer EHR and using specific visit types. For instance, there's evaluations, there's medication management, there's therapy. There's testing. So they will establish that. they'll say, okay, this is going to be a virtual visit. So there is, they mark down that this is, Zoom has to be put, a link to Zoom has to be put on the calendar. The patient will receive a confirmation email and a second confirmation that has that link on it for Zoom. At the same time, the clinician will receive a link that is ready to go. And at the time of the appointment, I will see flash up either in the EHR or in my email, patient is in the waiting room. The proverbial virtual waiting room, and I should go and get on that link and allow them in. There we have it. And I can tell you that the notable snafus, did the patient have enough bandwidth on their Wi-Fi, all these kind of problems, we slowly but surely solved, at least most of them. As I mentioned, this is the process we take for virtual visits. Now, we could just close up the hospital, I guess, or close up the outpatient clinic, couldn't we? Because all virtual visits, no, they're not appropriate for everyone. And increasingly, I'm seeing articles about which group are certain types of kids in, age, maybe even socioeconomic status, diagnostic status. But generally what we ask ourselves is it clinically appropriate to have a virtual visit? What is the patient and family preference? Because if someone wants to come in, that's the default. That's the default. If you want to come in, we'll give you a real live appointment. Now, we might find out that the child is running around, taking off their mask, taking off your mask, and we might advise them that maybe a virtual visit is better in the future. So we do have, provider preference does account for something. Regulatory appropriateness, well, we have to figure out, one of the things, distance, as I found out moving from Texas to Massachusetts, is that distances aren't quite as far. And we have people coming in from Connecticut, Rhode Island, all of New England. And guess what? They're in different states. And guess what? I'm licensed to practice in Massachusetts. I don't have a license in these other states. So we have to figure out what is appropriate. Who has to come in? Because they have to be seen in Massachusetts. They can't be seen in New Hampshire or Maine. Finally, environmental and operational changes. You know, we've had put up plexiglass partitions on site. We've used a whole lot of wipes. We've used a whole lot of masks. And what do we have to do? And that's changed a little. We no longer have to wear eyewear. The mask, we no longer, I think they're, even though N95s are, you know, still the safest thing, it's not essential that we use them. Post-COVID, well, how different are they? We don't know. The truth is, no one, particularly during COVID. Now remember, a lot of people have been treated via virtual visits, but during COVID. So that's always going to be a question. When COVID goes away, how good is anxiety? What we do for anxiety? How good is it virtually? How good is depression? How good is parent training? All of these questions have to be answered. Essentially, we have to go through all the evidence base and we have to do it over again as applies to this. Administration. Well, again, we have to think about what we need to do. And initially, all the staff went home and they worked from home. So who comes back? Who comes back? What's medical administrative necessity? Who has to come back? Can we design, and we improved our ability to do a lot of things at home. folks were able to do something. They did it. Well, we started giving actually everyone laptops. Every clinician, every administrative person who was seen to spend any time at home, we said, we're not going to worry about another health equity thing. We didn't worry about people getting their own computer. Now, those first few weeks, first few months, yes, we relied on people having their own computer, and thank goodness most people did. But as we filled in the gaps and we realized not all computers are created equal, we understood that we have to give everyone a computer. I can tell you it's both good and bad in terms of meetings. I do miss being with my colleagues in the same room, unmasked, and that's not happening yet, quite happening yet. We have a number of meetings which you have your option. You know, you can do virtually or come in, because people do have, all of our clinicians have on-site hours. But it's helped. It has helped. It would have been a disaster. Communication would have been a disaster if we weren't able to communicate. And some of these communications, we're going to decide what meetings can be Zoom or better Zoomed, and what meetings aren't. Well, I mentioned communication. Increasingly, the patient portal really took off because we needed to have that ongoing communication with parents. We weren't going to see them, actually be in the same room with them for a long time. And that includes messaging, exchange of materials such as rating scales, school forms. We can send it, as you know, just like we would email, and it's secure, so that's great. Hospital-wide communication, and that's really important because there is no way, even though I'm down at the bottom of the hill on Boylston at 2 Brookline Place, I'm going to even walk up those blocks in the middle of the winter to hear my boss make a speech. So, hey, I can do it. I can do it virtually. I can join in virtually, and I can leave without people staring at me. Internal web page, great. We were able to keep up every day, have guidance, so people didn't clog the phones to environmental health and say, well, what do I do in this case? What do I do in that? We tried to spell it out as much as possible. So having that access on the hospital website, the internal hospital website, is important. Here are just some common patient portal features. It's expanding. Wow, they can do everything. And I think what we hope will happen soon is we'll really be able to push things and get things filled out. Push things, items that need to be filled out to patients and families, and have them fill them out electronically and press a button and send it back. Release of information, lab results, discharge summaries, refills, many of these things, just about most of these things we can do, but we can do them better. Interoperability. Well, interesting enough, I don't get kids in to the office as much. What do I miss? What do they miss? They miss, well, I do doctor things, believe it or not, even though I'm a psychiatrist, and some of those doctor things are weights, heights, blood pressure. I don't have that. I say, go to your PCP and get that done. Well, now, because of the portal to our affiliated practice, I can go into their medical record, and look at their weight. I can look at their last blood test for this and for that. I can write a note to their PCP. So that interoperability is really important, particularly when the kids can't come to your site. Now, usually the primary care doc, even though they have their own virtual appointments, it's a little bit easier. They're in the neighborhood. It's not as far. There are a number of different issues. One of them being, of course, that not all patients at Children's are children. And once they turn 18, everything flips. They have to sign releases of information. They control access to the portal. And that's been tough. That's been tough. The hospital has been pretty good. There's a bunch of things that happen right away. When kids turn 18, you know, the computer, the system can read that and tell us, yes, you've got to get the release of information signed, and family and all. This is what happens. You know, the kid gets control of gets access. I mentioned some diversity, equity, and inclusion issues. One is we have a lot more information to disseminate. I talked about disseminating hospital policy, this sort of thing. We can listen not only live, but we can listen to a taped copy of interesting discussions that relate to COVID, that relate to hospital functioning, et cetera. The patient portal allows for more active two-way communication. It's no longer dependent on, you know, whether you have a phone or time to sit by the phone. Listen, even if a patient or family has a phone, it doesn't mean they can get a hold of me right when they want to. But if they send a message to the patient portal, yes, I can read it at, I'm sorry to say, 9 o'clock at night and respond to it. So a greater number of people can take advantage of that two-way communication. Virtual visits, of course, limits costs, they limit inconvenience. People don't have to worry, you know, a lot of parents will phone in, will dial in, link in from their offices, not home, you know, if it's early enough, not home, or if anyone's at school or what have you. So it's much more convenient. Interpreters, we promise everyone that we're going to make you understood. And there is a large immigrant population in the Boston area. We're able to really access immediately, really anyone who speaks pretty much any language. And definitely the more common ones, Portuguese, Spanish, Mandarin, as such. So these are the sorts of things I think that really speak to diversity, equity, and inclusion based on our electronic profile. Clinical pathways. What are clinical pathways? Clinical pathways are descriptions of care. So I'm going to give you an example that if you were treating depression, you were a doctor treating depression, what do you do to diagnose the child or screen for the disorder? What do you do for the first treatment? What do you do for the second treatment? And this is spelled out in fashion. Well, you say, well, that one makes it pretty simple. Anyone could do that. We don't need doctors anymore. No, obviously you do need doctors. You need doctors to interpret. And but suffice it to say, it evens things out. It makes it possible for PCPs to know what to do in certain cases. Part of clinical pathways is measurement-based practice. And I know before I mentioned that we would talk about rating scales and sending them out to folks and getting them back. This is something that we need to do better at, and there's, I think some EHRs have been able to do this as of recent. That is, have a thing there, I press a button for depression, and a certain number of rating scales go out to the family, that through the pathway, people are able to electronically fill them out. They come back, they're scored automatically, they're put in a database, they're graphed. That's what we need, and it's on its way. It's on its way. It's partially there. Obviously now we have e-pharmacy. In fact, I I think it is, I could print out a prescription. I think I can put out, but I can tell you that's probably about 1 in every 500 prescriptions that I will actually print out a paper prescription. Some states require, at least for controlled substances, require you to go through e-pharmacy because, you know, people could forge prescriptions, et cetera. We can use algorithms, and this is something, again, the DHRs can track, specify what and when. And even though this offers a great boon, a great opportunity for individual patients, even more so for a lot of patients, that is big data. If we have clinical pathways and we want to see how a particular approach works, we're able to do that. We're able to do that. And we're very excited. People don't have to go through necessarily a randomized clinical trial to see if approaches work or don't work, or how do they work relative to one another. Outcome measures, I'm just giving you, these are some outcome measures that we send out. Now we send them out either paper and pencil. We have a particular app called Tonic that allows us to set it up beforehand, and then it goes out at certain measures go out at certain intervals, and then they come back. But it doesn't quite have the functionality that we want. Remember, I told you about the functionality that I could not only send it out via schedule, but I could also force it out. Just press a button, and that particular measure would go to that particular kid. They'd be able to score it and then come back, et cetera. So these are some of the ones that we use. Now, I'm not going to, I thought to push this link, but this is our dashboard. And, you know, of course, one of the reasons that I guess the EHR is really the ultimate technical, is the keystone to technical aspects in the hospital. And this gives us information that we're able to take. And we create a dashboard where we can look at any time, certain variables. How many kids were seen? How many kids were seen for multiple visits? How many visits? The average number of visits. How many kids were admitted? How long were they admitted? Were they admitted for? A whole host of things. In fact, so many things, and you can imagine how many data points there are. We have an executive dashboard where we only choose those items that we're going to really look at. And that's usually just access, the number of kids who've received services, that sort of thing. But you can imagine anything that the data will cover, and the HR allows you to input that data, you can get it on the dashboard. Well, guess what? We're a training institution, and we have to train the next generation, not just in EHR. In fact, frankly, the EHR stuff, you know, you're going to be trained several times. The EHR, well, I don't have to worry beyond, say, 10 years, because I'll be retired. But beyond that, if you were coming in right now and you had a 30, 40-year career, you probably would have to orient yourself to 3, 4, 5 different iterations of electronic medical records. So it's important not only that we make that our trainees become digitally smart, and by being millennials in this particular group, they are generally pretty digitally savvy, but we want them to be able to use those in their practice in much the same way that I described. Tracking the patient experience, assessing their performance. In other words, we have, for instance, an app called New Innovations that many training programs, medical training programs use. What are they able to do? Well, you're able to not only assess how your trainees are doing in your program, you can compare those to national means, and you can cut it and slice it. You know, how do the male versus female trainees do, et cetera? How do the foreign medical graduates do? In fact, so much so clinical informatics training. In fact, I got off the phone with one of my dearest old friends whose daughter is in town. And she's she's a physician, working part-time in the children's emergency department. But she is doing an informatics fellowship. So that's available. Not just a special thing, that's available. And so we have kind of super users, I would call them. And finally, supervision. You know, I'm able to look at a person's note, not just their description. I'm able to look at their note and guide them, you know, on not only clinical issues, but also digital issues. Here are some medical informatics competencies. I think these are obvious. Patient care and procedural skills, medical knowledge, practice, etc. All of these things, digital isn't the only way we can teach them, obviously. They do have to come into the hospital, and they do have to learn how to see patients and examine patients in real life. But they're going to increasingly be in a digital environment with more and more things digital. Clinical decision support systems, I mentioned UpToDate. It's a very common medical, where different medical specialties, different problems, for instance, in our attention deficit disorder, and there might be several different programs. So if I'm a doctor and say, oh, you know, this is not my regular thing that I do, but I can look this up. I can press a button on the EHR, and that topic will come up, and that'll help me make a decision, help me on dosing, So what do? It reduces variance in practice, because everyone, you know, this is UpToDate is, for instance, is very popular and very common. So that has an important aspect in training. Collaborative care, we mentioned the folks in the PPOC, the educational community. MCPAP, who knows about MCPAP? MCPAP is something that started, I think, about 20 years ago in Massachusetts, wherein providers, pediatric providers, receive consultation from people like me, from specialists in psychiatry, in child psychiatry. So they call up anytime they can call up, and we're supposed to answer within a half hour, an hour or so, and we talk to them about their case and give them phone consultation. If that's not sufficient, we schedule them and we see them either virtually or in site for a real consultation. What does that do? Well, we can't take all the patients. Not all the patients who have mental health problems, all the children with mental health problems can be seen by psychiatrists. But we at least share our expertise, and that's been a very successful program. But it has an enormous database, literally thousands upon thousands of kids who've received consultation for various things. So we often look at that as a group. EHR, I don't think I need to really discuss that. EHR documentation, I think everyone knows that. Privacy, this is something that's really important, because right now, under law, you can look at your medical record at any time, and there's nothing that's off limits. In fact, I know my wife expected to get a sensitive lab result, and she was going to get it almost certainly before her doctor. She was going to have access to that almost before her doctor. So that's an issue of what access should minors have. How can we say you have a 14-year-old who's sexually active using drugs? Well, we're not supposed to share that information by law. So how do we resolve that? Well, we have a way of designating a note confidential based on certain criteria. So we're able to do that. We wouldn't be able to do that on a paper and pencil chart. We mentioned decision making and clinical pathways, applications. I'm gonna end on applications, and I'm sorry. We, not only will we go digitally, but we'll have interactions that are not based on time, that people can access lessons that aren't on time. That is, you can have a cognitive behavioral therapy that's essentially taped, or has different decision-making junctures where you can make a decision. People are developing virtual reality headsets for anxiety disorders and exposure disorders. So it's those combination of things that I think really kind of round out our discussion of digital. It's not just setting up, it's not just the infrastructure of psychiatric care for children, it's the actual content of care as well. Thanks. Questions?
So I have a friend that has a child and she's been trying to find a therapist for her son. And she says every place she's gone, they don't take the insurance, there's no opening. What do you tell a parent? Like, where should they go? Like, what resources are available to them? Because I think finding care is the biggest issue right now.
My heart goes out to people because I know. I get this every day. We have, I'm embarrassed to say how big our waiting list is. My staff just cannot do anymore, digital or otherwise. They'll burn out or leave. So your insurance company, ask your insurance company for a detailed list. They're developing ways in which we can get ghost lists, where a bunch of people are listed who never take people. But call your insurance company, get a list, and be persistent. That's what you need to be. Don't give up. Be persistent. People get in. It may take a few months, but people get in. When we follow up people on our waiting list, a good number of them have gone in, and particularly the ones who are active, who keep at it. It's the best I can say.
I had a question about burnout. You told a really nice story about how if you had the sniffles, you could go home and still have your appointments. But in the past, that would have meant that you had a day to catch up on your paperwork or whatever, right? And that's now gone, and so now you're working a lot more. And I imagine your staff is too.
Well, you're absolutely right, and the pressure is on ourselves. We basically ask, if you feel like working, and most of them will volunteer, I feel like working, I'm just going to work from home, work. If you don't. We have a number of different COVID positive folks, and some of them hardly feel it, and some really it lays them out for a few days. So we try to give people, but you're absolutely right. We need to figure out how much to do, because burnout is an issue. Other questions? Well, again, thank you very much. It was
Thank you, Dr.
pleasure to be
Bukstein.
here.
That was a great presentation. Just want to let folks know that we are going to be having a break now for the next 45 minutes. This room is actually going to be open for our closing keynote. We will not be split any longer. So take a break. Please visit our sponsors. They have some great stuff. So giveaways and things. And there will be a raffle at the end of, well, actually during the reception. So make sure that if you wanted to get in on those raffles that you stick around. All right.